Right. Good afternoon. And another day with different things around, especially with testing and concerns and issues and directions and other ideas with coming forward in many sectors on our command table we've been working at, as well as with I believe the Premier and the Minister has already spoken to this, and something that's very important to both Dr. Yaffe and ourselves to make sure that we're doing all the things we can do to monitor and direct the situation, as well as to get in the data that would help our modelers to look at how we're doing overall as a province, and especially how we're doing with bending the curve and flattening the curve. And we're hoping to hear more from them as the week goes on, because they want to get this week's data in that would assist them in understanding the situation here in Ontario. So before I go into some aspects around that, I'm going to hand things over to Dr. Yaffe to talk about today's numbers, and then I'll be talking a bit about those after she gives those to you. So over to you, Dr. Yaffe.
Thank you. So just to remind you, today's numbers reflect the data as of 4 o'clock yesterday afternoon from the Public Health Unit's Integrated Public Health Information System, IFIS. There are a total of 5,276 confirmed cases of COVID-19 in Ontario reported. This is an increase of 550 from the previous report. About 53% are female, and 36% are 60 years of age and older. 52% are people who live within the Greater Toronto Area. We have had a total of 174 deaths reported, unfortunately, which represents an increase of 21 deaths from the previous report. 58 outbreaks have been reported in long-term care facilities and involving 78 deaths, some of which are lab confirmed, others are epidemiologically linked to cases. Of our cases, 2,074 have been resolved, which is almost 40% of the cases. And cumulatively, we have had 580 healthcare workers who have tested positive. 605 of our cases are currently in hospital, which is a slight reduction from the last number of 9 less. Of those, 246 are currently in ICU, and 195 of those are on a ventilator. Lab testing, which is subject of interest, which we'll hear more about. So far, we have tested almost 85,000 people in Ontario. Currently under investigation, 1,102. And in the last 24 hours, we have tested over 3,200 people involving close to 5,000 specimens, because each person can have more than one specimen tested. I'll turn it back to Dr. Williams.
Yes, well, thank you. And so when we're looking at the different aspects around the testing, and this has been a strong interest to myself and Dr. Yaffe and our command table over the last week. Last week was a hard-working week for our laboratory team. They were quickly validating all the other labs up, and we didn't get them all validated until partway through last week. And then we didn't get our backlog cleared up until Friday. So we were eagerly anticipating to move ahead with the increased capacity in that, and over the weekend we wanted to make sure that that held steady, and it did. And so as a result, we were working with our command table to ascertain if we were to increase the capacity, what would we do with that in order to make sure that we were getting what we needed to understand the current issues in Ontario. As you know, from the get-go, I said our main target here is decreasing morbidity and mortality in the province of Ontario, and to try and keep that as low as we can in spite of some of the dire predictions through the modelers and the different projections and some of the data from other countries, which have been very concerning in that regard. So in light of that, then what should we do with that extra lab capacity rather than just producing numbers? How will that affect and keep down our morbidity and mortality, and how would we use that in such a way to not only do that, to look at our priority areas, our areas of most concern, And that, well, of course, one of the biggest one we have is our long-term care facilities. And as you know, last week I did put out, earlier in the week, and that, the end of last week, a directive which was to increase the outbreak sensitivity of long-term care facilities, including things to take more proactive approach in a number of areas, because we've been concerned about the outbreaks in our long-term care facilities. And as Dr. Yaffe's alluded, unfortunately, the number of deaths that have been attributed to COVID-19 in these facilities. So along with that, we really did want to ramp up our testing, as well as we have been looking at, okay, do we have the amount of reagent and the swabs, etc. So all that was coming together over the weekend, and we had already put in our priority list and had our experts meet to say, how would we do that in the long-term care facilities, etc. So we have, and we'll be modifying that. We'll have some updates on that as we go forward, and to get that refined list out, which will result in a lot more testing being done. But that relates a lot to monitoring our at-risk population in long-term care facilities, assisting in keeping those cases under control, trying to keep the mortality down and morbidity down in those jurisdictions, and of course impact on the healthcare workers that are in those facilities. So that's our number one priority. We also have our other at-risk populations, which includes First Nations, and we've had our we've had about 12 cases on First Nations in Ontario. Our first and northern remote one has been reported, and this is concerning. And we want to make sure that when we undertake this in partnership with the Chief and Band Council, along with federal authorities and with various organizations, health authorities in that area, that we would be there to give them the testing and the results as soon as we can to assist in dealing with that and coordinate off as quick as we can to limit any morbidity and mortality in that community. So that was our first priority. The other one we wanted to look at is that can we have any more numbers of tests and that to supply that would assist our modelers and looking at how we are doing compared to other global situations in there. And we, all along, as you know, we have in our definition that we have people who have contact history of travel and or case contact. We're to use a self-assessment tool, telehealth. They could go to an assessment center or talk to public health. And those that had mild symptoms were noted as a case in our minds, as a probable case. And they were asked to isolate for the 14 days. And we would follow up with them as we did with public health to see how they're doing. That was because at that time we did not have the lab capacity to do all those people, because the most important thing was not that their test was positive and they had a positive test. We took it that it was positive, and they undertook the same type of isolation as if they had a lab test. In that, of course, if they did get worse during that period, they'd be sent to the assessment center or onto the hospital for further testing and admission if necessary, because the testing in the hospital center, which all along we have said throughout our whole process that physicians who had assessed a case in hospital or otherwise that felt, even if it didn't meet the criteria earlier on of a travel or contact case, if they wanted the testing done, they could order the testing and we would not turn them down on that. And we did a lot of testing that right from the beginning. So this only adds to that, because the testing, it helps to declare if the person is COVID positive, and that affects the care in the hospital, the need for isolation facilities, and the further protection of staff in that setting. So therefore, in that setting, the test has even more meaning and is critical and important for the physicians and healthcare workers to handle it appropriately. But all along, it was our pretense, our hope, that as we added all these other labs on, and we got enough reagent, and we got enough swabs, and all the components that are in there, that one day we would be able to do not only 5,000, but 10,000, and potentially 14,000. And we have got to that day. And so we'll be announcing some other changes there to do even further testing on other ones, and we'll put that criteria out as we've been informed of what are the wide variety of signs and symptoms of people presenting early on with a COVID-19 infection in there. So we hope to have that coming out and to utilize as much as we can to document those numbers. And with that data, I think in the long term will help to support our modelers to give an idea of how are we doing, how are our public health measures doing, and how successful we're doing in that regard. So I think that's important to note. And as I said, with our data and information, you notice the number is up again today, even though from some of our labs is slightly different. We know there's a delay from the community labs getting their data in. That's a new partner with us. That gets to the center, then goes out to the health units. They have to enter it into the data system that we're using for our daily reports. So some of that 550 is delayed from over the weekend, and as health units are dealing with a large load to get that information in, to assess it and to assure that it's correct and to move it forward in that regard. So I'm still optimistic as we go into the weekend, as we get that backlog of data entry as well as the other information, we'll start to see a real representation of what the daily numbers are. And from some of our local centers, they seem to be coming down. But again, as I said before, I would want to be advised by those over a period of time, much like you hear BC saying, while they're optimistic, they want to see this as a sustained bending of the curve, not just a temporary drop. And so we're still watching that carefully over the weekend as we now, by this Friday, will complete that 14-day period when all the ones who did the traveling during that time will have completed their main incubation and quarantine period. And we would expect that in the future, cases addressed to traveling, which is still about 18 to 19%, dropping slightly, should pretty well go away unless there's the unusual travel that comes back, and that still may be important. So those are the main things that we are addressing today in the aspects here. Our public health measures, we've looked at some more data and information. And I would say, on a positive note, Ontarians, well done. It shows you're still sticking to the task of doing the physical distancing, staying at home. The amount is equal to other provinces, not slightly better. So I think you're doing a great job. Doesn't mean there's some people out there are choosing to be less than responsible, and we have to continue to use means to remind them to stick to the task. But I think in that sense, as you stay at that and work at that, and I know it's not easy for some, you have to strive, and I think everybody's getting a certain mode and grid of how to do that and how to handle that. Our public health measures table is looking at if we were able to come down and steady down and plateau out and come and flatten the curve, what should we do about lifting things and looking at that? How should we advise the Premier and the Cabinet in that way accordingly? So we're already looking at that, same as British Columbia is looking at that, because we like to look down the road and say, if we get to that decision point, how do we turn back the dial a bit at a time, carefully, so we don't lose all the investment that we collectively as Ontarians have put into this over the last 3 to 4 weeks. So with that, I'm going to open up for questions from our media on the line.
Okay, we'll take questions from the first caller.
Your first question comes from Cynthia Mulligan with City News. Please go ahead.
Hello, Doctor. When we look at the modeling projections that were done last week, that were released on Friday, it showed that there would be roughly 800, under the best case scenario, people in ICU. And yet, we are seeing now that it's significantly lower. It's about 246 people in ICU. Do you need to change the modeling projections? Do you think that they were overly elevated?
Well, I know that our modeling people have, they said they would be directed by the data. And it was their sense, if you don't change things and we don't make some impacts, especially with our public health measures, we could be heading towards 800. I think you raise a very good point, and I know in talking, they say they're optimistic about re-looking at it with the data and may give a better forecast in the future. So again, they said we will be looking at the data, we will be assessing that and changing the projections accordingly. Much like with more up-to-date weather reports, your forecast is different. And so the fact that they may have to change it into the positive direction is a good thing. And I would agree with you. I think if we look at that, we are better than we thought we would be at this time, both in the number of cases as well as in the hospitalizations, ICU, and deaths at this stage. But again, let's get a few more days of data in there. Let our modelers have a look at it and see, much like a report card, how are we doing? Have we improved? Have we moved off the Italy scenario more towards another scenario, much like you heard BC doing? So I'll be looking forward to their report and their analysis to see how are we doing in their projections.
Follow up?
And my second question to you, Doctor, is I know that Ontario has struggled to get its testing numbers up. You've mentioned reagent was an issue, but every province has had that issue, and we have still been the lowest per capita for testing of any province in this country. Are health cutbacks, public health cutbacks, partially to blame? City Councillor Joe Cressy points out that there hasn't been an increase in public health funding in 7 years.
So the amount of testing, and when you do rates and comparisons, it's really, as I said before, it's not a really valuable thing to do because you'd have to compare us to another province of the same size on how that's going. I can say, compared to pretty all the provinces, including the ones that have some better rates, we have done processed more tests than any province in that. Now, does that give me solace to say that's good enough? That wasn't good enough for us. That's where we want to increase the capacity even further. And so I think per capita is a little bit eroding. We can do other rates on population. We can make ourselves look better than some other provinces by doing that. But it's not a matter of who looks better. It's a matter of how collectively we're doing on a Canadian basis, and are we together branding the curve for Canada, because we're all in this. And while my counterpart to the east in Quebec is dealing with a large surge this time, I would be in a situation there, and I guess I would imagine we could get up to 50 or 60,000 tests, and he wanted us to help out. I would do some tests on his behalf to help him. It's not a matter of who is better and who has more advantage. We're in this together, and we got to work at that. As far as public health funding, the public health unit funding doesn't cover costs of doing lab testing and the reagents and that kind of aspect there. So I'm not sure where that comparison comes from. The key is the public health contact tracing and how we're doing that, and that's why we have moved quickly to allow public health units, and I know Dr. Yaffe's been working hard on that, to bring up that resource and deal with what is needed this time to ramp up to an unprecedented event. We have not had this global pandemic like this before, and what are those resources and that. So it's a matter of taking a look at what do we need right now, how do we get to that to the health units with many resources, individuals, staffing, IT supports, all those things, so we get the job done, because it's critical, as it has been up to now. Our case contact management is vital. It has during our first phase with the episode following in January from Wuhan. It was very necessary when we had the influx and the whole issues with from Europe, and we handled that. And now it's even more important as we go through this phase when we finish up the travel one, because as some have said, this is not going to, even if we get down and we flatten down and have a quiescent moment, we're going to have to still do all the, I call it mopping up, the cases when they appear, and we'll still come through now and again, and we have to do that case contact with much diligence over the next number of months ahead. So while some of the load, if we were lucky, not lucky, but intentionally get the hospitalizations, keep them down below that number, that we don't have a scenario, that's great for our healthcare system. We want to keep morbidity and mortality down, but it doesn't mean the work for public health will get any less. So I think we have to look on the way forward. I'm not sure if Dr. Yaffe any comments about the public health role and the responsibility with case contact, or have I said enough already?
I think you've covered it.
Okay, well, thank you.
Next question.
Your next question comes from Chris Herholt with CP24. Please go ahead.
Hi, doctors. Good afternoon. Doctors, could I just ask you, could you definitively say right now that there's no correlation between the fact that we lead the nation in deaths reported and we lag every other province in tests per capita? You can say right now that there's no relation between those two things?
If I take the number of deaths, as you alluded to there, and because you're doing per capita, you're doing a rate. If I put that on a rate on our population, our mortality rate is not only as good, in some cases better than other provinces. Do I take solace in that? I don't think so. But if you're going to do rates and per capita with testing, then you have to do rates and cover everything there. And when we put our deaths over our 14.4 million compared to some of the smaller jurisdictions, that gives an unfair balance in there. And so I'm reluctant to do that kind of comparison just to try and make Ontario look better. I still think those deaths, all of them, are important. I'd rather have no deaths. But I know what we're facing. I know the issues that the modelers have given to us. I know the reality of other countries. So we have a big challenge. Our mortality rate isn't any greater than other jurisdictions. We're less than the United States in that kind of aspects at the moment. But they're going through a lot of things at the moment. We're less than Italy, but it's a different situation. I can't compare us totally to Italy in that regard. And again, just because we're better in that regard at the moment doesn't mean any room for complacency and not trying to do harder. So I don't see the correlation between the two because you're comparing two different things altogether, numbers and rates.
Follow up?
How about the fact that 17% of the people's specimens that were turned around in the last 24 hours came back positive? Shouldn't that alone tell you that you should be testing way more than you are right now?
You want to do the positivity rate?
Yeah, I think the bottom line is we want to do more testing. We're working very hard now to increase the testing and expand the criteria and, encourage clinicians to test people if they are concerned that the person has symptoms that may be indicative of COVID-19. And that, we're very much hopeful that we will go up. We do have capacity. We need more testing.
Next question.
Your next question comes from Haley Cooper with News Talk 1010. Please go ahead.
Hi, Dr. Williams. Hi, Dr. Yaffe. The gap between women and men becoming infected is widening. So men, it's just over 46%, and women, it's just over 53%. Are women more susceptible to the COVID-19 virus?
I'm not aware of any studies that have shown that. And in fact, I'm kind of surprised that women are higher. I think in previous studies from other countries, I think men are usually higher. So it may reflect more where people are exposed. And it's not a big difference right now, but it is leaning toward women. Of course, there are more women in the population, a little bit more. But I think we'll have to watch that.
Follow up?
And my follow-up, Quebec has released its worst and best case scenarios, and included in those is the virus's peak, which Quebec says is coming somewhere around April 18th. So why can Ontario not release the estimated peak here if Quebec can?
So, I mean, our modelers were asked, and again, I think Dr. Brown was reluctant to give an exact date, as would be reasonable. He was looking at sometime around the middle or after the middle of April at the same time. So they're not that different. I mean, if you look at the peak of hospitalization, ICU, and deaths in there, he wasn't talking about the peak in the case numbers. So I think they're not too different. It's within the range of possibility and variability. So when I saw the Quebec numbers and the projections, that seemed to make sense to me.
Next question.
Your next question comes from Rob Ferguson with the Toronto Star. Please go ahead.
Hello, doctors. It seemed to me the Premier took you to the woodshed about 2 hours ago on not taking full advantage of our testing capacity for the last 4 or 5 days. I wonder what your reaction is to that and his suggestions that all frontline workers be tested, all healthcare, more healthcare workers, more nursing home workers, and why not grocery workers?
What was the last one, Rob?
Grocery workers.
Yes. I didn't see it as taking to the woodshed myself. I know that we were working on it, and when the Premier joined our command thing to make some comments, ask some questions, it was right along the line of what we were doing. So it's nice when you're exactly on the same direction with the Premier, and he's driving for it, and he wants the reagents, and he wants the testing done, and we need that kind of support from our leaders that are going to bat for us at all levels. And I know the Premier is working hard. He's going day and night. He's heading towards the federal level and different levels, trying to do whatever he can, not only with laboratory testing, but with PPE. And that's what we want to have. And so I would say it more like coming as the a captain saying, you want this, I want this, so let's make it happen. And we're saying, let's go. And so it wasn't anything on the line of being taken to the woodshed. It was more like just do it, and I'll support you all the way. And so we're saying, okay, let's do it. And so we're heading out on that way to have that happen. I think as far as the other thing with the frontline workers, we've always had as our priorities, remember, of our priority groups when we didn't have as much capacity to make sure that healthcare workers were prioritized in that level and frontline when they needed to be done in that state there. I think what the Premier was looking for is some widening of how that would be, because there has been some concerns, and much like with healthcare workers, remember we talked in the past about having essential critical positions that could be looked at to be allowed to come back before the 14-day quarantine. Fortunately, that for most of them, that 14 days is over, so it's a moot point. But at the same time, there are some first responders that have, say, someone who has been exposed to a group, and therefore a segment of a team or a platoon or something is off, and that certainly does limit the capacity of that force to carry out their duties and responsibilities. And so we're trying to look at how we might utilize testing for two purposes. One, the primary one is to protect the first-line workers if they have been exposed, and can we identify them as soon as they're symptomatic to make sure that's done on a priority basis so that they would get all the care they need to do, and mostly of all to say that you have to maintain isolation so you don't put your fellow members at risk and compromise a larger workforce. And then finally, like with the healthcare workers, how would you assess as soon as you can, having followed a reasonable quarantine period, that you're now safe to return and not compromise your platoon or your group in that basis? So I think the Premier is trying to look for some more directions in that regard. No, he didn't mention grocery workers in that regard that I recall in that aspect.
Follow up?
Yeah, no, he didn't mention grocery workers. I was just mentioning it because some public health people are mentioning that. But my follow-up is, when will the new testing directive be coming out, and why wasn't it ready sooner? Because it does seem that like 4 or 5 days of full capacity has kind of gone to waste.
In order to, we're trying to ramp those up as fast as we can. We want to make sure that our expert tables met and said, if you're going to deal with the long-term care, which is our first big priority, and I know that's a big priority for the Premier and our Minister as well, ask our experts, okay, what's the best use of testing? Testing for the sake of testing and just racking up numbers and doesn't give you any direction is not only a poor use of resources, it distracts you from getting to the task done. So we want to ask the experts to say, if you had to test here and there, what's the best way to do it, and to lay those down. Get them agree upon that. Then you have to get all that out to the local, regional Ontario health offices for the distribution of different materials. How are you going to handle that in presumptive outbreaks, bigger outbreaks? So all those guidelines have to be put out, because it doesn't make any sense to throw it out and see if it lands somewhere. You have to put it out in a consistent way, and that's okay if you've got only 4 or 5 things to deal with, but we have well over 400 to 500 to deal with, and that means because not only long-term care homes, but retirement homes. So we're dealing with a lot of organizations, a lot of groups, and we want to make sure that everybody's going to be pulling at the oars at the same time, and we have to make sure that's consistently. And if we're going to ask them to do it, do they have the swabs? Will they get the tests in? How are they done in a timely fashion? So we don't want to go out and then trip going out the door. We want to make sure we do it right. So I know urgency sometimes dictates value in that sense, and we feel it's urgent in one way, but it's really, if you rush out and make mistakes and people are misinformed and not dealt with correctly, that would be of more concern to me. So we want to do it and do it right as we get it out the door. So we're working as fast as we can with our partners in Ministry of Long-Term Care and Seniors Ministry to make sure we have those things in place and to support the organizations and the staff in those institutions as our first priority. And at the same time, we do not want to drop the other priority groups, especially I mentioned before, our Indigenous populations, prisons, as well as homeless, and to make sure we don't miss on some of those key ones as well. So while we're driving to that, we do not want to drop the ball on the others. And as I said before, priorities for dealing with healthcare workers in hospitals and hospitalized patients, and ones in ICU and on ventilation.
Next question.
Your next question comes from Sabrina Nanji with Queen's Park Briefing. Please go ahead.
Hi, it's actually Queen's Park today. But Dr. Williams, I'm wondering, I know that the minister had talked about expanding the test criteria. Can you tell us a little bit more about who you want to see tested?
So I think in the general, because the details are going to be rolling out shortly, we want to look at the long-term care facilities. How when one, as we already remember my directive, we changed from the old prototype of the I needed 2 or 3 cases to call an outbreak. One symptomatic was a presumptive outbreak, and they start doing some aspects around there. So we want to do some testing right away, and we're trying to lay that out, what kind of protocol we will be asking them to undertake to assess that in that situation there, and then how would we roll out with larger numbers, etc. We're trying to roll out how we're going to continue to do the cases on First Nations, especially those in remote areas. And then we're looking at if we're going to ask our assessment centers to now do a wider range of testing individuals, not with our, I would say, our triad of the main symptoms, which is cough, fever, and shortness of breath. We've been aware of other ones that they may present in slightly atypical, and giving them the latitude, and we'll try and lay those out to them, how they might do that, to give them more flexibility to do tests on those ones as well. Already they've moved that task up a little bit as we speak, because in the past they were testing about 60% of the people who came, and some who had mild symptoms were told they didn't need tested and they could do home isolation, which for the sake of that, most of them have and have resolved. But now they've already moved that up from 60 to nearly 75, 78%. So by bumping up even further, we're hoping to max up on our lab testing as best as possible, and to see, as far as the models are concerned, does it indicate anything further that we weren't aware of and we didn't understand, especially how does it impact on our overall mortality and morbidity, which, as I said, is our primary goal throughout this process, to keep that down.
Follow up?
Okay, and to follow up, can you just clarify, if you will be testing people with influenza-like illnesses or symptoms, like will they be included, and I guess why haven't they been included up until this point?
Let's Dr. Yaffe to comment on that.
Sure. Influenza-like symptoms are usually things like fever, malaise, cough, trouble breathing, which are the classic symptoms of COVID-19. So people who have presented with those symptoms, if they're very mild, as Dr. Williams said, in some instances, because of the capacity issues, they have not been tested. They've been told go home and self-isolate, and if you get worse, follow up again. But people with significant symptoms like that have been tested and should be tested for COVID-19.
Our next caller will be the last. Next question.
Your final question comes from Allison Martell with Reuters. Please go ahead.
Thank you. So given that Ontario did not test some number of probable cases and some pretty consistent reports of people with symptoms who are not being tested or followed by public health units, by what order of magnitude do you think your case counts underestimate the prevalence of this virus in Ontario?
So by the prevalence of how many people are active right at this moment, because prevalence is different than incidence, and cumulative numbers are different again. So the fact is that, our total number of cases that we might have had, because remember, a number of people, as we have tested, or we've been aware of some, and we've been aware of the data, where positive, as we talked about the data from our Special Advisory Committee, people with so-called asymptomatic or pre-symptomatic or posse-symptomatic symptoms, a large number of people, especially the younger ones, who said they're asymptomatic and tested positive in other countries, when they asked them later, they said, I guess I was. 75% said that. So we're dealing with a lot of people who had probably they had travel history and felt a little off, had a very mild illness. Some didn't have a mild illness. Some, of course, got referred on and went into hospitalization, and some were in ICU, and that's true. So I don't think people who are in need were turned away with severe illness from hospital care and ICU, and if they needed ventilation. So I don't see that, because our mortality numbers and our hospitalizations would be well up above our percent, because we've stayed about the 6% hospitalization and the 2-point-odd% of ICU admissions. If the premise is that we missed a whole bunch, then our hospitalization rate over our case ones would be larger, like 8 to 12 or 13%. So we haven't seen that in there. And so are there possibly people out there who had such a mild illness that didn't know it? I would think so. I think there's probably quite a few. Again, did that number greatly drive our mortality and morbidity? By the data I have, it hasn't. In that regard. One reason to try and get some larger, more data numbers, as I said, our modelers would like to have that in their database to give us a better projection of how we would go forward. In that case there, at least as far as I've been advised by our public health units and by telehealth and that, all those who had symptoms and connected with a travel or case contact were advised either through our self-assessment tool, telehealth, or assessment centers or by public health to isolate for those 14 days, and a number could keep calling back or follow up to get information on that. Does that mean there were some people that might have been missed in a population of 14.4 million? I would think there's some, but again, I have not seen that affect our overall mortality and morbidity rate thus far, and in fact, I think as one of the other reporters asked, on the projection from our modelers, we're below what they anticipated would be. So there's the good news story there, but I think, again, I don't think that there was anyone in there because the public health case contact management, if you're identified as a probable case through your history, you're asked to isolate, and then we went and checked some of your contacts and notified them that you're a potential contact of a case, and we would follow them. So we didn't disregard those ones. We monitored them as if they really did have a positive test in that. So that's one of the main things we want to do with public health and our case contact management.
Last question.
Yeah, well, let me just read you a brief account that's been circulating this morning. My father visited an ER yesterday, 11 days of cough and fever, x-rays showed pneumonia, had returned from Florida 2 weeks before onset, was sent home with antibiotics, was not tested for COVID. Is that consistent with your guidelines?
No, it depends on the physician, and that was one that was assessed in a department. In that, I would have to ask that and review that with what the hospital record, the individual, and that. So, I think that if the travel history combined with the signs and symptoms are very much concerning and indicative of COVID-19. So I would have to say that would indicate to a lot of our assessment centers and physicians that they probably would have undergone that testing, but I don't know all the details of the case, except I guess someone has given the account to you or in the public forum.
Okay, unfortunately, that's all we have time for. Thanks, everyone.